we will continue, and our next speaker, Dr. Martina Porter, with a retrospective review of triggers, demographics, and stress of patients diagnosed with telogeneffluvium at specialty alopecia clinic.
Thank you. So this is our study, and I'd just like to note that I currently work at Beth Israel, but all of the research was conducted at our hair research unit at Mass General Hospital, and both of our institutions are affiliated with Harvard. So I don't have any disclosures relevant to this presentation, but when I was doing my research fellowship, I did have support from grants from pharmaceutical companies and the National Psoriasis Foundation. But, so telogeneffluvium, or TE, is a non-scarring alopecia, and it occurs approximately 3 months after some inciting event or trigger. And then it tends to resolve spontaneously, and the thought is that the hairs that are in anagen phase are prematurely shifted to catagen and then telogen with the subsequent excessive hair shedding. So the diagnosis of telogeneffluvium is primarily clinical. We rarely biopsy it. And the things that we look for in terms of clinical signs and history are a positive hair pull test, diffuse hair loss, more than 50% of the scalp with bitemporal recession, shedding more than 100 or 150 hairs per day, an absence of scarring or inflammation, and then also we look for resolution or regrowth of the hair. And the things that we were really interested in are related to the triggers of telogeneffluvium, because there's been papers published that list many different disorders that can be related to telogeneffluvium, but there's no real definition of the incidence or which ones are more likely to cause the disorder. So the triggers that we think of are autoimmune diseases, nutritional disorders, endocrine disorders, following pregnancy, changes in medications or initiation of new medications, febrile states and illnesses, and patients' emotional stress. And there was a study that looked at stress related to telogeneffluvium from a patient-reported perspective, and they found that the degree of stress a patient reported was not always in concert with the physician-assessed degree of hair loss. So there were quite a few patients who reported a lot of stress who had very minimal hair loss from a physician's perspective. And so at Mass General, what we do is a very standardized process for seeing all of our new hair loss consults. And most of our patients are referred either from self-referral or from their primary care physicians, other dermatologists inside and outside our academic practice, as well as other specialties. And we try to be very methodical in the way that we collect data when patients come in. So all patients, when they're first seen, they fill out a very extensive hair loss intake form that asks them about their medical history, family history of hair loss, any treatments they've tried, any changes in medications, new medications. It asks about emotional stressors. We collect patient-reported outcomes in terms of quality of life measures, and then we review all of this in our 30-minute initial visit with patients. And we have a very detailed history and physical exam. We take the same photos from the same angles of every patient, regardless of what their hair loss diagnosis is. And for telogeneffluvium specifically, we do the hair pull test. And all of this has been IRB approved by our local institutional review board. And I mention this because when we do these assessments, we collect all this data retrospectively, but it also gives us a very good baseline, so as we follow these patients over time, we can prospectively examine how our treatments are working, and the patients can also compare their photos before and after, because a lot of patients will come in and say they've had no change and they've actually had significant regrowth. So this study specifically seeks to characterize the type of patients with telogeneffluvium. We wanted to look at the specific triggers of telogeneffluvium, and we wanted to summarize the impact of telogeneffluvium on patient stress levels. And so from August 2016 to June 2017, we saw 271 new hair loss consultations. Of these, 69 patients were diagnosed with telogeneffluvium, which is a very large portion of our total initial consultation. It was over a quarter. And the patients that we saw ranged in age from 17 to 87 years, and they were distributed fairly evenly across the age ranges, but we did not have any pediatric patients that presented with telogeneffluvium, and most of our patients were female. In general, we tend to see mostly female patients. 81% of our total consultations were female, but 90% of the patients that were diagnosed with telogeneffluvium were women. And then also, a lot of people think that telogeneffluvium can unmask other hair loss disorders, and we essentially found a similar sort of pattern where 35% of our patients who were diagnosed with TE had another cause of hair loss that presented simultaneously, and most commonly this was female pattern hair loss in about 80% of those patients. And compared to our other consultations, where we were looking at diagnoses, the majority of them only had one diagnosis, and only 13% had 2 different diagnoses for their hair loss disorders. And so this is a picture of a patient that we saw. On the left is her initial consultation, and she had been in general good health with no changes to her medications and no other real physiological causes of her hair loss, but she noticed this rapid hair loss, and it occurred a few months following her husband's death. And this picture is actually from 5 months after when she first presented. And the picture on the right is following no treatment at all. She had significant growth of her hair, which really supported the diagnosis of telogeneffluvium. And it also kind of leads to this next slide where, of all the patients we saw, the most common trigger of telogeneffluvium was emotional stress, and that was in over a third of the patients, almost 40%. That was the main cause or trigger. The second most common was more than 10 pounds of weight loss, and this was followed by any changes in medications and primarily hormonal changes, either thyroid or hormonal contraceptive changes, accounting for these triggers of telogeneffluvium. But things that I think we used to think were more common causes of telogeneffluvium, like illnesses and hospitalizations and surgeries, autoimmune disease, were not very common in our cohort of patients. And we had very, very, very few postpartum patients presenting, and the ones that we saw were actually patients who had presented after miscarriage and not full-term deliveries. And then, because we do this extensive intake form and patient-reported numeric rating scales of stress, we can actually compare them across different diseases and diagnoses in our hair loss clinic. And telogeneffluvium actually has one of the highest stress levels of the different types of hair loss disorders that we see. Patients who had just telogeneffluvium alone had an average stress level of 7.1. And patients who had telogeneffluvium plus a second cause of alopecia had a stress level of 7.7. And this was in comparison to patients with alopecia areata that we saw who only reported stress levels of 5.9, and patients with scarring alopecias like planopilaris and frontal fibrosing alopecia who only reported a stress level of 5. So pretty significant differences for telogeneffluvium. And then in conclusion, the main takeaways, I guess, from our study are that non-scarring hair loss, even though your hair returns, it can still be a significant stress to patients, especially if they have 2 disorders. And that rather than medical causes causing the triggers of telogeneffluvium, we actually found that stress and weight loss were the most significant causes. And for patients who are seeing for clinicians who are seeing patients with TE, it's really important to go through a detailed history with them and identify some of these stressors, because counseling them may actually help them better cope with their transient hair loss, and reassuring them that their hair will grow back as long as they don't have a secondary cause can be very helpful. And still, because we have so many patients with telogeneffluvium in our hair loss clinic, we do want to better characterize these patients and explain why some patients are more susceptible to TE and why there's greater incidence of TE in certain demographics, which in our case was adult women who may just be more stressed. But the limitations of the study are retrospective in nature, and that we were relying on patient recall, and that we probably have some selection bias as a tertiary academic referral center. And then I'd just like to acknowledge the Hair Academic Innovative Research Unit, the Hair Unit at MGH, and the PI, Marianne Senna, who really made all of this possible. And then also the North American Hair Research Society, who provided me with a travel grant.
Very interesting talk. And dear colleagues, any question or comments?
from what you know of hair physiology and the precipitating causes that this condition does, can you postulate or share with us your ideas of how this comes about, the mechanism of this process?
I am not the greatest at hair physiology, but I do know that they have looked at stress and that there are certain mediators, and emotional stress in particular, that cause hair loss. I'm not sure in terms of which phase it's affecting, but they think that that can be related to the telogeneffluvium.
I mean, it seems to be a really important a laboratory model for understanding the process of exogen in the hair follicle cycle. Getting its controls is a real challenge for us in the field. So it's good for you to do this.
Thank you.
So, one question that struck me, and maybe I didn't get the data exactly right, but it seemed like 80%, 79% of your telogeneffluvium patients had female pattern hair loss?
No, so it was of the patients that had 2 different hair loss disorders diagnosed, one of which was telogeneffluvium, that was about 39, I think, or 40% of the patients. 79% of those patients had female pattern. So the majority of people who had 2 diagnoses, which was not the majority of patients with telogeneffluvium, had female pattern as the secondary cause.
Okay, so maybe around 30%.
Yeah.
Okay. Thank you very much.